Greetings, and thank you for the opportunity to share our exciting work on sub-ischial transfemoral socket designs here at the meeting. I will be presenting today with my collaborator for the last 13 years, Dr. Stefania Fatone.
As Ryan mentioned, we are co-developers of the sub-ischial socket technique we are presenting today. The technique exists in the public domain, but research and development of the technique was funded by the Department of Defense through 2 grants. We have no other disclosures or conflicts of interest to report regarding the work we are about to present.
First, I would like to start by sharing the history of how this collaboration began and has turned into a major development in transfemoral socket technology. So I graduated from Northwestern in 2003, and during my residency, I became intrigued by vacuum technology and all of the buzz around the benefits of the system. My first clinical experience with vacuum was with this patient pictured above who saw rapid wound healing in his first fitting. One successful case turned into many, and I was intrigued as to whether this technology would be beneficial for transfemoral users. Since there was not a manufacturer-recommended approach for using vacuum in this population at the time, I began fitting transfemoral users in a similar manner to transtibial users with a liner and a sealing sleeve. The system worked very well with the patient until they sat down and put a hole in the liner or the sleeve. The movement towards a sub-ischial socket was merely an accident as I modified and trimmed the brim to eliminate flares that cut the liner. Initial users were not quite as stable, but really liked the feel. So I began to approach the sockets to make them more stable with a low profile brim.
After experimenting clinically for a few years and convinced that he was onto something, Ryan came to NUPOC in 2007 to see if there might be interest in collaborating with respect to further development and research on the sub-ischial socket technique. We spent a couple of years writing grants and finally were funded by the Department of Defense in 2010 with a Technology Development Award. This allowed us to formalize and further evolve Ryan's ideas, resulting in a technique that we began teaching in 2015. At about the same time, we received funding from the Department of Defense for a comparative effectiveness clinical trial of the sub-ischial socket. During this time, we published 2 papers describing the initial vacuum version of the socket and then a modification of the technique to allow it to work with passive suction. The results of our clinical trial are currently in review and will hopefully be published sometime this year. Improvements in prosthetic componentry, including socket design and suspension, have a critical impact on the functional abilities of individuals with transfemoral amputation. Traditional socket designs include ischial containment sockets, which limit hip range of motion and function. New sub-ischial designs may improve hip range of motion and overall function. When coupled with vacuum, they would also offer better suspension. While the primary goal of our sub-ischial socket was to improve comfort, we thought that if hip motion was also increased and suspension improved, it may be possible to also see improvements in function. While we have ample clinical examples that our sub-ischial socket works, we wanted to share with you some of our thoughts as to how it works. Despite the prevalence of transfemoral amputations, surprisingly little research describes which transfemoral socket design features are important during gait. Particularly relevant for transfemoral amputees is the stability between the socket and residual limb in the coronal plane during walking. It was Radcliffe who first proposed that compression of the proximal medial soft tissue was important in coronal plane stability of a quadrilateral socket. Later, ischial containment was added to further improve coronal stability of the socket. While Ryan was experimenting clinically with the concept of sub-ischial sockets at NUPOC, we were exploring ideas about which transfemoral socket design features are important during gait. In a small pilot study published in 2014, we tested the relative contribution of ischial containment socket ischial containment and proximal medial soft tissue loading to comfort and biomechanics during walking. We used the Marlow anatomical socket to systematically explore the idea because it is easy to isolate the ischial containment portion of the socket and make it removable without disrupting other aspects of the socket. So we built a test socket with a removable ear so that we could assess socket comfort and gait biomechanics with and without ischial containment. And we also created removable medial panels that allowed us to vary the amount of proximal medial tissue compression, giving us 6 socket conditions that we could test in random order. Our data showed that with the ischium contained, tissue loading did not influence socket comfort. With no ischial containment, the socket was equally comfortable with high tissue loading, but the medium and low tissue loading conditions decreased comfort significantly. We didn't observe any effect of these changes in socket features on gait biomechanics. These results provide some insight into the importance of tissue loading in a sub-ischial socket, given that removing the ear effectively changed the socket to one that was sub-ischial. We theorize that compressive forces on soft tissue act to stiffen the tissue and reduce relative motion. During walking, both proximal medial and distal lateral forces act on the socket, causing coronal plane toggling of the socket on the residual limb. When tissues are pre-compressed, this toggling is greatly reduced. If we consider hypothetical force displacement curves, for the same forces, Dmax1 and Dmax2 are the maximum displacements of the socket when tissue is uncompressed, while D1 and D2 are the reduction in displacement of the socket we might expect when tissue is pre-compressed by the liner and socket. Clearly, a sub-ischial socket provides no pelvic support, and hence all weight-bearing loads must be borne by the thigh. This requires that the socket be able to distribute forces all over the thigh, as shown in this diagram, especially if we are to avoid concentrating all the forces on the distal end. In order to understand whether our socket does indeed provide support over the entire thigh, rather than just being concentrated on the distal end, we conducted a simple clinical study. The study design was based on observation of check socket fittings, as shown here in this photo, which suggested that individuals with amputation are able to place almost all of their body weight on the residual limb when it is clad with the liner and socket, suggesting that the liner and socket help reduce weight-bearing forces at the distal end, likely acting to distribute normal forces across the residuum surface. To assess the proposed theoretical role of tissue compression and preloading in creating a system where weight could be borne over the entire residual limb, we conducted a small clinical study wherein individuals with amputation were asked to transfer as much weight onto the residual limb as they could tolerate in 3 randomly ordered conditions: a bare limb, liner only, and liner with socket. If we look at body weight data from a scale placed beneath the residual limb, we can see that while there was a significant difference in percent body weight between all conditions, the most dramatic change occurred once the socket was donned over the liner. Similarly, when we asked the subjects to rate the pain experienced in each condition, we saw a significant decrease in pain only when the socket was worn over the liner. This data provides indirect support for the idea that the socket redistributes forces away from the distal end and onto the thigh.
So there are several key differences between an ischial containment socket and the new flexive socket. The main goal is to eliminate the containment or the support from the pelvis, which is the most common complaint of transfemoral socket users. In our sub-ischial socket, the medial trim line is typically 10 to 25 millimeters distal to the ischial tuberosity, as it is still very important to contain the proximal medial soft tissues. The lateral trim line can be patient specific, but it is best to keep it higher for patients that have shorter residual limbs, as this helps increase surface area and maximize support. Patients are made stable in the socket by soft tissue compression. As was mentioned, we rely heavily on weight bearing through the thigh, and this can be achieved by pre-compressing the limb with specific liners. Compression from the liners help drive the positive model rectification in location and magnitude. For example, the liner in the image has compressed the limb by almost 1 inch in the subtrochanteric medial lateral measurement. Cylindrical liners are used to pre-compress the proximal medial soft tissues, which are very soft and play a crucial role in coronal plane control. The liner is rolled onto the limb as proximal as possible as to contain the soft tissue medially. This helps to avoid development of adductor rolls. Liner measurement and casting should also be conducted in the seated position. The proximal edge of the liner acts as the initial socket trim line. The softer the liner, the more undersizing is needed to sufficiently compress the limb and the soft tissues. In terms of selecting liners, we prefer silicone liners with fabric for their durability. This is especially important when reflecting the liner over the proximal brim. The fabric facilitates donning as it decreases the friction between the socket and liner when pushing into the socket. Firmer liners with cylindrical profile will best compress the soft tissue, making it easier to achieve socket stability on the residual limb. Our preferred liners align with those that have high compressive resistance, as reported by Kegel in this publication and the accompanying Liner Assist website. You can see that silicone liners tend to have higher compressive resistance than TPE liners, and that the Relax 3C liner from Oster has a relatively high compressive resistance compared to other liners. And as such, it is one of the liners that we highly recommend when starting this technique to use sub-ischial socket designs. However, these firm liners won't necessarily work well for all patients and limbs. Other liners, such as the Oster sealant, can work well with our technique, but as the liner becomes less firm, the socket has more work to do to be stable on the residual limb. The subtrochanteric medial lateral measurement is used to determine how much material will be removed from the lateral wall during the positive model rectification to provide that coronal plane control. The impression is taken in the seated position over the firm silicone liner. The cast should capture the proximal edge of the liner to keep the mold from sliding down on the patient's residual limb. So one unique feature of the NU sub-ischial socket technique is that material is only removed from the positive model, and the rectification is broken down into 3 steps. The first step is to remove plaster along the proximal lateral quadrant for coronal plane control. The second step is to flatten the posterior wall to improve sitting comfort. And the third step is to blend these 2 modifications. This last step is important for rotational control, as we are also connecting modification number 1 and number 2 at the pocket hollow. To facilitate teaching our technique, we developed documentation in the form of a socket work form that incorporates a mold reduction algorithm. While volume is reduced during modification, the location and amount of reductions are determined based on whether the subject's residual limb tissue is soft or firm, and the residual limb shape. The rectification map on the top right of your screen shows the ideal modification strategy for the NU socket based on digital comparisons of 30 unrectified and then rectified molds. The dark red area shows the area where the most plaster is removed, with less material removed in the green area. And the gray area shows areas that have no material removed. This socket lends itself well to CAD manufacturing and we have had various groups provide positive feedback on CAD implementation of our socket design. The concepts underlying how sub-ischial sockets work are not new when you explore the history of transfemoral socket designs, but we have the ability to improve upon outcomes experienced by the patient with the use of more advanced materials. The concept of bony centering was explored in the 1980s by repositioning the tissue. Today, most firm liners accomplish this just by donning. We have also mentioned the narrow ML concept and the importance of this measurement. In the rectification process for the sub-ischial socket design, we have a tendency to follow the NSNA guidelines of removing material predominantly along the lateral aspect of the model. In the chick socket fitting, the patient should be able to stand and see completely into the socket. We assess soft tissue containment within the socket and ensure that the proximal socket trim lines don't make contact with the pelvis throughout hip range of motion. Alignment for the sub-ischial socket follows the patient's thigh in the coronal plane and is set up based on the manufacturer's recommendation for the knee in the sagittal plane. Adduction can be added based on the length of the residual limb and during dynamic alignment as needed. There is no need to preflex the socket as you would for ischial containment. However, if the patient does have a hip flexion contracture, you should accommodate for that in your sagittal plane alignment. When teaching the sub-ischial socket technique, we encounter interesting opportunities, like using a video vector analysis system in Norway to assess dynamic alignment. This particular example shows visually that there were no gross differences between the ischial containment socket and the new flexive socket in terms of vector orientation at mid-stance. In terms of troubleshooting socket fit, check socket trim lines are often too high initially. This can be addressed by gradually heating and flaring the trim line to the point where the IT and ramus do not make contact with the edge of the socket upon weight bearing. This may be a slow process, but it is important to go slow as that you maintain as much containment of soft tissue as possible. In terms of overall volume, the patient should be able to see completely in the socket with slight resistance during donning. They should have total distal end contact, but not be end bearing. Rarely do we have issues with the distal lateral end of the femur, despite not adding any sort of relief. Dynamically, you might notice gapping of the proximal edge of the socket, either anteriorly or laterally. You can use pads to adjust for these gaps. Padding posteriorly to minimize anterior gapping, or padding medially to minimize lateral gapping. If you are having rotational issues, there are likely two causes. One is that the posterior lateral corner needs to be more snug, or the other is that the subject may be muscularly weak and can't control the socket during swing phase. It is important to recognize that pads not only fill volume, but can also help change alignment of the socket because there is no pelvic containment. This plays out particularly for the posterior and medial pads, which upon completion of the check socket fitting could be placed on the opposite side to reduce material on the positive model. Having provided an overview of how we think the socket works and highlighted some of the aspects of the technique, we wanted to show you some case examples. In terms of indication and contraindications, it has been my experience that most above-knee prosthetic users can be fit with one of the versions of the NU sub-ischial socket. Patients in whom you would expect to see some volume change should be fit with a suction version of the socket with a seal-in liner. Vacuum can be beneficial for more active patients where moisture evacuation could be beneficial. At present, the sub-ischial socket does require a liner, so if a patient does not want to wear a liner or has an allergy to these materials or silicone, our technique would be contraindicated. So I have been using sub-ischial socket designs for more than 15 years and have fit quite a few patients with some version of the design. Patients with limbs that have scarring, invaginations, heterotopic ossifications, bone spurs, skin grafts, and flexion contractures have all been successfully fit with a sub-ischial socket. This includes patients with both myodesis and myoplasty. The length of the residual limb is important, as the longer the limb, the easier it is for the socket to work. But I have been able to fit a patient with a femur of about 4.5 inches. I'll describe that case shortly. So this is a snapshot of my clinical practice and the types and proportions of patients to whom I have fit one of the different types of or the versions of the sub-ischial socket. You'll see that I have fit a lot of suction sockets. Most new users get a suction version of the socket just because it's more amenable to the management of volume change. Many of my patients have amputations due to vascular issues and mostly receive suction versions of the socket. I fit the socket to patients with all levels of mobility. Not surprisingly, K2s almost always get a suction version of the socket as well. So in clinical practice, it's always nice to work with the young and active prosthetic users who can walk on just about anything, as they always make us, the practitioner, look good, whether we deserve that or not. This is one of those cases. So this is a patient who has worn a version of the sub-ischial socket for just about all of those 15 years that I've been fitting these. I would like to highlight a more typical case presentation here of an older patient who has a long and strong residual limb. The photos above show the contribution that the liner makes to providing a more firm residual limb that is ideal to fit with this type of socket. So shown here is the patient walking with her ischial containment socket on the left and the sub-ischial check socket on the right. What I have seen with this particular case is that the patient walked with a step 2 gait in the ischial containment socket so as not to impinge on the pelvis as she extends her hip. Within a few minutes of walking in the sub-ischial socket, she adopted a slightly improved step length without discomfort from the proximal brim. In this second case, we have a patient with a soft, very soft residual limb, and you can see how the liner acts to firm up the tissue. Again, we are using the liner to force a limb into a more ideal shape, similar to a firm and strong residual limb. Again, the liner is the foundation of the system. So the video on the left is the patient again walking with her ischial containment socket, and the video on the right is the sub-ischial socket. The patient remarked that in less than 5 minutes of walking in the sub-ischial socket that she did not have the back and buttock pain that she experienced in her old prosthesis that she had worn for the past 8 years. So as I mentioned, here is the case that we have with a patient with a 4.5-inch femur. On the slide, I have an example of a poorly fitting liner in the middle, as well as a great fitting liner on the right. The sizing for both liners is the same, but the stiffer gel profile and the thicker the gel profile on the picture on the right helps create a more ideal shape and limb tissue consistency. So in this example, you can see that I have used a custom seal-in locking liner. This combination is extremely helpful in patients that have a shorter residual limb to help maintain a seal when the patient is in the seated position. I believe the pin in this case is not really a main means of suspension, but really just acts to help keep the seal securely in place, regardless of the patient sitting or in any sort of other limb position. So this patient has been in a sub-ischial socket and has been wearing that successfully for about 3 years. While there are still some gait abnormalities, the patient is comfortable and confident and is able to use the prosthesis without any additional support or assistive device. So I think as a field, we have seen that there's been a big push into incorporating some sort of adjustability into sockets. And in this case, we've done this with sub-ischial sockets so that the patient can make some minor adjustments themselves. I have been incorporating this adjustable design into many sockets to allow the patient to make micro and quite frankly, macro adjustments to the volume of the socket and not just change the pressure of the sockets in some other scenarios.
While Ryan has used sub-ischial sockets successfully in his practice, we have also been working to disseminate the technique to other prosthetists and conduct additional evaluative research. As we mentioned earlier, we began teaching the technique to prosthetists in 2015. Since then, we have taught the technique to 136 prosthetists in the United States and 127 prosthetists internationally. The technique has been described by prosthetists as straightforward and reproducible. And as you can see from this message from an Australian prosthetist, it is possible to learn and implement the technique just by reading our publications. At this point, we have enjoyed teaching this technique all over the world. In particular, we've given multiple courses in Japan with our colleagues at the Kobe College of Medical Welfare, where we have made a major impact, which our Japanese colleagues have been tracking and presenting at conferences. As we mentioned earlier, DoD funded us to conduct a larger randomized crossover trial comparing comfort and function in the ischial containment socket and new flexive sockets. We just completed this study, and so I'd like to share with you some of our results. The clinical trial involved a crossover design in which each subject was randomly assigned to receive one of the two sockets, wearing it for 7 weeks and completing 3 identical data collection sessions at 1, 4, and 7 weeks after socket delivery, before crossing over to receive the other socket and repeating the process. Data collection included socket comfort score, 3D gait analysis, and performance tests such as the 5 times rapid sit to stand, the 4 square step test, and the T-test of agility. Subjects also completed the OPUS questionnaires about lower extremity functional status, health-related quality of life, and satisfaction with device. We hypothesized that at 7 weeks, the new flexive socket compared to the ischial containment socket would provide increased comfort, which was our primary outcome. We also hypothesized that it would result in faster times on the performance-based tests and have better lower extremity functional status, satisfaction with device, and health-related quality of life. We hypothesized that it would allow greater prosthetic side hip range of motion, in particular increased hip extension, which would in turn lead to increased prosthetic side step length and walking speed. However, we did not expect a difference in step width and lateral trunk flexion over the prosthetic limb during stance between sockets. Recruitment for this trial took place between April 2016 and May 2019. We enrolled 30 unilateral transfemoral subjects. 25 of those subjects completed the study. We had 18 subjects with full data sets from all 6 time points and 7 subjects with partial data who had 1 or 2 time points missing. Reasons for withdrawal related to the sockets are shown in the table and were quite varied across subjects. Of the 25 subjects for whom we had data, 6 of our subjects were female and 19 were male. Mean age was relatively young, on average at about 46 years. But time since amputation was quite long on average at about 23 years. Most of the subjects had amputations due to trauma, with a handful due to cancer and 3 due to vascular issues or infection. All subjects were either K3 or K4 ambulators. All participants in the study received 2 new sockets fabricated by prosthetists with experience in each socket design. Components distal to the socket were standardized within participants. We used their usual knee and gave everyone an OSSA foot with Unity vacuum pump. Prosthetists were allowed to make modifications to the socket during the 7 weeks to address fit issues as subjects accommodated. In terms of our primary outcome of socket comfort, the graph shows the mean score at each testing time point for each socket. At 7 weeks, the mean comfort score for the group of subjects was significantly different between sockets. The socket comfort score for the Neuflexive socket was 1.7 points higher than the ischial containment socket at 7 weeks. If we look at the difference in socket comfort score at 7 weeks across individual subjects, we can see that only 2 subjects had a difference of 1 point that favoured the ischial containment socket. 2 subjects had no difference in score, and the rest had a 1 to 5 point difference in favour of the Neuflexive socket. For 4 subjects, the difference in socket comfort score exceeded the published minimal detectable change of 2.7 points. With regards to the results of the 3 performance-based tests, you can see that there was no significant differences between sockets at 7 weeks. In terms of the OPUS questionnaire, there was no significant difference in lower extremity functional status or health-related quality of life at 7 weeks, but analysis with a linear mixed model showed that the Neuflexive socket scored slightly higher at 7 weeks for OPUS satisfaction with device compared to the ischial containment socket. This linear mixed model allowed us to compare all time points in the analysis, making it just a little bit more sensitive. Finally, when we look at some of the gait data, we saw no difference in key variables such as prosthetic side hip range of motion, step width, or lateral trunk lean, regardless of whether the subjects walked at a self-selected slow, normal, or fast walking speed. As a final comment about our results, 19 of the 25 participants chose to remain in the Neuflexive socket upon study completion. Collectively, these results suggest that for young, experienced, and highly mobile unilateral transfemoral prosthesis users, the sub-ischial socket improved comfort and satisfaction with device without compromising function. We wanted to share with you a case study we published showing some long-term data from a sub-ischial socket user. This subject had kept every sub-ischial socket he'd worn over 10 years. What was interesting was that while they varied in shape and material as our technique evolved, when lined up chronologically, they could be stacked into each other as shown in the photo on the right, with the oldest socket on the top and the most recent cast of his limb on the bottom. This suggested that some change in volume had occurred. Since the subject maintained a stable body weight over this time, this suggested that some linear change in volume had occurred. We digitized the sockets and compared volumes of comparable portions of the sockets. What we saw was that over 10 years, the subject's residual limb volume increased approximately 30%. When we compared the distal and proximal circumferences, we saw that the proximal circumferences increased more than the distal over time. This data suggests that despite limb compression, a patient who is active with the socket doesn't necessarily atrophy. It suggests that this subject increased muscle mass, given that the greater increase was in the proximal circumference, where muscle bellies are located. While this is data from only one subject, we have heard other anecdotal reports of subjects increasing volume such that they needed either a larger liner or to have the socket remade. Concerns about the sub-ischial socket design have been raised. For example, Harvey et al. Queried whether we would see an increase in femur fracture, heterotropic ossification formation, and hip and low back pain. However, we don't have any clinical evidence from over 10 years of clinical use of the sub-ischial socket that these are commonly encountered issues. Current research evidence is too short to provide insights regarding these types of issues. However, one case study of a bilateral amputee suggests the resolution of back pain when transitioning from ischial containment to sub-ischial sockets. While conducting our clinical trial comparing the ischial containment and euflexive sockets, we learned something about the issues to potentially watch out for when transitioning patients to subischial sockets. In compliance with our IRB requirements, we recorded adverse events with both sockets over 7 weeks. It's important to note that this was a non-systematic evaluation, as assessment of adverse events was not a formal goal of the study. In our study, no serious adverse events occurred. All the events that occurred were anticipated before the study commenced, as they are common issues generally encountered with any type of socket. As you can see, the adverse events we observed occurred for both sockets.
So what we've learned about transitioning patients between socket designs is that the patient's motivation to change is a big factor for success. If they've always wanted to get rid of the proximal brim, then they will really like the sub-ischial socket, despite the fact that it is still a socket with all the incumbent issues. However, current research suggests that it should be more comfortable without a substantial change in function. The sub-ischial socket can in some cases unmask weakness in the hip and in core muscles. If motivated, walking in the socket will in of itself improve strength. However, targeted physical therapy can also help. If a patient has never worn a liner, you should anticipate that the limb volume will shrink and that the patient will likely experience some sort of transient skin reaction, including itching, redness, blisters, and sores. Sometimes this goes away on its own as the limb acclimates to the being inside a liner. Sometimes it requires a change of liner, and sometimes it is a socket fit issue that can be addressed. So we hope that you have found this presentation informative. Again, I would like to thank you for listening to our presentation, and please check the NUPOC website for additional resources on all of our exciting projects and collaborations.